In this video, we're going to be talking about endoleaks.
What is an endoleak?
Well, I'll explain what is an endoleak. I'll tell you the different types of endoleaks, and especially how to treat the most common one. And if you don't know what an endoleak is, don't worry, a lot of doctors don't know what they are. But if you're watching this video, you probably were treated for an abdominal aortic aneurysm, or you have one. So what is an endoleak? Essentially, endoleak is something that can happen after an endovascular repair of an abdominal aortic aneurysm, which is also called EVAR. So I'm going to start with the basics. An abdominal aortic aneurysm is a dilatation of the abdominal aorta. The aorta is a 2-centimeter blood vessel that is located in the abdomen and takes the blood flow from your heart all the way to your legs. An aneurysm is when a blood vessel gets larger, it dilates and gets big. And the risk of an aneurysm is that they can rupture, and if they rupture, they can be fatal, essentially. You can die from them. Once an aneurysm in the abdominal aorta reaches about 5 centimeters, the risk of rupture becomes very high, and we usually treat them. And there are two ways of treating them. One way is to do an open surgery, which is rarely done these days, but basically you make a big incision in the abdomen, you cut this aneurysm out, and you sew a tube so you can reestablish the flow to the legs. Nowadays, we usually treat this in an endovascular fashion. What that means is that we put little tubes to the groins, and we navigate under x-rays, and through these tubes, we can deploy like a PVC pipe inside the aneurysm, so we can redirect the blood flow inside the aneurysm so that aneurysmal sac or that dilated area can essentially collapse. And again, that's called an endovascular aneurysm repair. And these PVC pipes, we call them stent graft. So if you have a dilated pipe and you put a tube inside, all the blood flow should be going through the new tube and nothing should be reaching the walls of the pipe. But that's not always what happens. And sometimes the blood can still find ways into that aneurysmal sac. And that's what we call endoleak. And there are 5 main types of endoleaks. A type 1 is a leak around the ends of the graft. So either in what we call the proximal end, which is the upper end, or through the lower end. So basically the graft is not well attached to the blood vessel and the blood is leaking through that. That can be very dangerous, and that usually needs to be fixed right away. And it's usually fixed at the time we actually do the original procedure. So it's rare to see these types of leaks afterwards. Now, a type 2 endoleak, that's the most common one, and that's the ones we see all the time, and they can be very challenging to treat. So essentially what happens there is the blood will flow backwards into the sac from small side arteries like the lumbar arteries or the inferior mesenteric arteries. And we're going to talk a lot more about this one since it's the most common, but let's go through the other ones first. The type 3 endoleak is when the leak goes through a gap or a tear in the graft in between the graft components. Because usually the way we put them in is just not one tube. We put multiple tubes and we build them like little Legos kind of thing. And if they're not attached well, that's what's called a type 3 endoleak. Type 4 endoleak is when the blood seeps through the fabric of the graft itself. And it's really rare these days because the materials are much better. It was more commonly seen when we initially started doing these procedures and we didn't know what was the best material to use. But nowadays they're really rare. And most of patients that had the older type of grafts, they already have them fixed. And the way you would fix a type 4 endoleak would be to realign them. And finally, a type 5 endoleak is not really an endoleak, but it's called endotension. And it's when we essentially don't find an endoleak, but the sac is still growing and not shrinking. And that one is tough to treat because we don't know why they happen. But on the other hand, they are not very serious because even if they rupture, if there's no blood, it's not going to bleed. Like I mentioned before, the type 2 endoleak is the most common, and that's what we're going to focus from now on. So type 2 endoleaks can happen in up to a third of the patients that undergo an endovascular repair of abdominal aortic aneurysm. But not all type 2 endoleaks need treatment. And that's because most of them, about 60%, will resolve in the first year after the procedure by themselves. Without doing anything, they will resolve. But if they don't, and especially if the aneurysmal sac starts growing by more than 5 millimeters over time. And that's because the growth means that the pressure is still building up and there is a risk of rupture. And also because if the aneurysm keeps dilating, that neck that is holding the device in place can get larger as well, and the device potentially could get loose. And that becomes a bigger problem. And how do you treat a type 2 endoleak? So essentially the goal of the treatment is to block the small feeder arteries so no more blood is entering the aneurysm. But that can be challenging because usually there is more than one blood vessel that is going there. It's just not fixing one blood vessel when you're done. And there are two main approaches to treat this. There is one that's called a transarterial approach, which is usually done through an artery in the wrist or in the groin. And essentially we do an angiogram. We insert a catheter and we'll inject dye and take some pictures and see which blood vessels are actually going to the aneurysmal sac. And once we find them, we can use a microcatheter, which is a tiny small tube. They're usually less than a millimeter, and we can navigate through the body under x-rays and find the vessel that is feeding the aneurysm. And then we usually use a special glue or coils to block these blood vessels. Sometimes we may get the catheter to go all the way into the aneurysmal sac, and with that catheter we can find even other blood vessels that are going there, and we can block all of them with the glue material. The transarterial approach is very good if the aneurysm is being fed mostly by the inferior mesenteric artery, but it is very challenging when the aneurysm is being fed by lumbar arteries, not only because it's difficult to get there, but also because often you have multiple lumbar arteries and it becomes very challenging to find them, get into them, and block them. And that's why when your endoleak is being fed mostly by lumbar arteries, we prefer what's called a translumbar approach. And that's when we go directly into the sac through the skin in the back. And we put a small needle into the sac under imaging guidance, of course, and then we can navigate the needle or even catheters inside the sac and find the blood vessels feeding the sac, and then we can use the same glue material we talked about to actually block all these blood vessels. The last option would be to do an open surgery and cut the aneurysmal sac and then find these blood vessels and ligate them surgically, which ends up being a big surgery, and it's rarely done these days because we prefer the minimally invasive ways that I mentioned before, which require no incisions and usually are only done with mild sedation or light anesthesia. These procedures are usually done in the cath lab or catheterization laboratory. They're guided by x-rays, and we use usually a small amount of contrast dye. Sometimes the translumbar approach can be done also under CT guidance, when we can use CT image to precisely guide the needle wherever we want, and then we would inject the glue through that needle. We can also use a combination of these two approaches because in most modern catheterization laboratories, we have something called cone beam CT, which we can use the X-ray machine to actually create CT images and confirm the location of these catheters and needles, so we can be very precise and provide you the best treatment. These procedures are outpatient procedures. Most patients go home the same day. Most patients have minimal pain or no pain after the procedure, and they can resume their normal activities, including driving, by next day. We usually recommend to avoid heavy exercising or weightlifting for about 3 days after the procedure so your punctures can heal and you won't have any problems. And what are the risks of this procedure? Like any other procedure, although it's very safe, there are some risks involved. I would say the main risk is a risk of a bleeding complication, usually in the axis site, in the groin. It is very rare because we use some plugs or closure devices to prevent bleeding from the site, but it certainly can happen. It's very rare, I've never seen one, but rarely you could damage an artery supplying the intestine, for example, and have a very serious condition called bowel ischemia. But again, I've never seen this type of complication. And there's also a chance that we can fix these endoleaks, but they may recur in a separate artery and may require additional treatment. Or there is a risk that even though we fix the endoleaks and there's no more endoleak, the aneurysm can continue to grow. But then, of course, if there's no endoleak, like we talked about, it's probably less serious. But overall, the success rate is really high. I would say the success rate is about 90% in experienced hands. But sometimes more than one procedure may be necessary for complete resolution of the leak. And how do we follow this after treatment? Well, we usually repeat the CT scan, usually about 3 months after the procedure, to make sure the leak is gone and that the aneurysm is shrinking or at least stable. Of course, it will take time for the aneurysm to actually shrink. That can take years. So essentially, type 2 endoleaks are very common after an EVAR or endovascular repair of abdominal aortic aneurysm, but with careful monitoring and targeted treatment, we can manage them very safely and effectively. If you had an EVAR, please keep your follow-up appointments and your follow-up imaging to make sure that everything looks good. But if you develop an endoleak, we can certainly take care of it.